Hello everyone again. So this is another video for the pituitary hormone part 1 that we discussed earlier. So in this video we briefly discussed about the hypothalamic pituitary hormonal axis. So you see that in this diagram, you see this is hypothalamus, this is the posterior pituitary gland, this is anterior pituitary gland, and these are the different hormones which are released from these glands. So for example, the posterior pituitary is releasing ADH and oxytocin, and anterior pituitary is releasing all these hormones which is targeting all these organs, and then mediating these effects. And then definitely what this is telling is that this is a feedback control. So I mean, in the PBL, I think so you guys did a great job. I mean, you recognized it correctly. So if you know this information, I mean, again, it doesn't matter how the question is framed. For example, if you see which of the following hormones is secreted from, let's say, posterior pituitary gland, you should be able to pick up that ADH or oxytocin if the answer choices are there. The question can be framed in different way, like prolactin is secreted from where? Hypothalamus, anterior pituitary, posterior pituitary, adrenal gland. So you should be able to pick it up where this is secreted from. So if you remember these, where the hormones are coming from, then you think so you should be fine from in this diagram. Okay, and then comes this table. This is a very popular table because we discussed this so many times in different lectures. So from this table, I think so the critical information here is that what kind of hypothalamic hormone is triggering hormone from anterior pituitary and which particular target organ it is targeting to, and how the effects are mediated, or what is caused, what basically the primary mediator of these effects. So, and then this positive sign is basically saying that this will have a positive influence, means this is gonna increase this, and negative means it's gonna inhibit it, right? So that's the meaning of this positive and negative symbol. So let's say if you know this information, the question could ask that TSH is modulated by which of the following hypothalamic hormone. So what is this asking is, where is TSH? This is TSH, and it is asking which hypothalamic hormone is responsible. So if you see an answer choice which is thyrotropin releasing hormone, then that's the correct answer. So if you remember this, I mean, then it doesn't matter, I mean, how the information is asked. You should make connections. Okay, so then yes, the drugs are definitely, I mean, yes, I mean, there's no way around. You have to remember these drugs. So, in terms of the brand name, I mean, I don't know how, but the generic name, yes, you definitely have to remember. So on top we are looking at the hypothalamic and anterior pituitary hormones, and then on the bottom we have this posterior pituitary hormones. Okay, so in this one is basically, first we discussed the hormones released from posterior pituitary. So remember there were two hormones released from these pituitary glands, so vasopressin and oxytocin. And as I told you that these are synthesized where? These are synthesized in hypothalamus, and they're stored here and then released further from the posterior pituitary. So the first thing we discussed was oxytocin. So the oxytocin, so this hormone is basically responsible for these two things, right? So it induces muscle contraction in the uterus and myoepithelial contraction in breast. So here this is responsible for the child birth, and here is for normal lactation, right? And as I told you, this is so beautiful. Mother Nature is so beautiful that during the second half of pregnancy, the uterine smooth muscle, they become very sensitive towards the stimulation of this endogenous oxytocin. How? Because they show increased expression of these receptors. So this is so beautiful. So I mean, from this, I mean, if the question asks you, you know, the oxytocin, what is true about oxytocin, and if you see this, and multiple other option, and then here, let's say, if say is the muscular relaxation, well, that's not correct answer, right? So I mean, if you know this information, doesn't matter how the question is framed. So make sure that you understand this. Okay, so the next is the mechanism of action. Again, we discussed this in detail. The basic thing is that you have to remember is that, you know, it's acting at G protein coupled receptors, and how the effects are mediated by a secondary messenger system, which is called as phosphoinositide calcium secondary messenger system. And the prostaglandins and leukotrienes are also involved in mediating the uterine contraction. So again, I mean, the question could be framed: what is the mechanism of action? What receptors it's targeting to? What is the secondary messenger system? Or what are the which of the following are involved in mediating oxytocin response or effects? So if you see all this information and then you see something which is not here, then that's a correct answer. Okay, then the clinical pharmacology. So remember, we just saw there that for childbirth and then for lactation. So here you have two conditions here, in which you want to induce labor and you want to augment the protected labor, and then you have another condition in which you want to stop vaginal bleeding. So in this case, let's say this is important. So this is important that, you know, in small doses, the oxytocin increases both frequency and force of uterine contraction. But at higher doses, it produces sustained contraction. So for these two things, what do you need? Sustained contraction or frequent and the frequency and the force of uterine contraction. So in case of delivery, you definitely want this. So for this, you need small doses. And if you really want to stop vaginal bleeding, then you need higher doses. So the question is that, you know, if there is a pregnant so in case of pregnancy, let's say, you need to augment the protected labor, which would I mean, you know, would you use a small dose or a large dose? Definitely you want to use a small dose for protracted labor, but in case of stopping vaginal bleeding, then you need higher doses. Plus, also the oxytocin is administered in IV as a dilute solution. Why? Because it can induce hypertension as well as hypotension, as well as at higher concentration it can activate vasopressin receptor, which can cause excessive fluid retention. So what is the vasopressin receptor is going to do? They will have antidiuretic effect. We'll see in a second. So again, the question could be framed: which of the following true regarding higher concentration of oxytocin? So in higher concentration, it is targeting vasopressin receptors, it's inducing hypotension, it is causing hypernatremia, and could cause seizures and death. So something else, that's not the answer. That's the correct answer. Okay, so then we got the vasopressin, which is also called as an antidiuretic hormone, and when it is released, it is released in response to increase in plasma tonicity and falling blood pressure. And then which receptors targets to? It has two major effects: antidiuretic effects and vasopressive effect. And these are the receptors involved in mediating these effects, right? And then deficiency of this hormone causes diabetes insipidus, which manifests itself as excessive thirst and frequent urination. As the name itself, antidiuretic. If you don't have, then you have those things, right? And then this guy, this ADH is short half-life, and then this guy, desmopressin, it has long acting synthetic analog of this ADH, which has V2 agonist property with minimum V1. So which one has minimum V1? Desmopressin. ADH has both V2 and V1. And why? We'll see in a second. If you look at that, so the V1 receptors are where? These are in smooth muscles, and V2 receptors are in tubule cells of kidney. So if these receptors are stimulated, they're going to cause vasoconstriction, and these V2 receptors are stimulated. They will increase reabsorption of water. So remember why this ADH was released? When there was low blood pressure. So whenever it is released, it is going to cause vasoconstriction in the blood vessel and increase water absorption. And together it will increase this total peripheral resistance and blood volume, and that will cause increase in blood pressure. So the bottom line here is that you should, I mean, if the question asks you, what is which receptor desmopressin targets to? Well, this primarily targets V2. It has minimum V1 activity. Which one is more long acting? Well, desmopressin. And why and what causes the release of this hormone? Okay, and then this was that why why don't would you use ADH antidiuretic hormone in case if the patient has coronary artery disease? Because you saw that this ADH was having both activity at V2 and V1, but this drug called desmopressin, it only has V2 agonist activity. So in case patient has coronary artery disease, if you use desmopressin, it will spare the V1 receptor mechanism, right, or smooth blood vessel constriction. Okay, and then in case if you have ADH hyperactivity, you have these antagonists. So let's say for your question, which one of these could be used in case of excessive production of ADH? The answer is these guys. Make sure that you remember which one is approved for which condition or which indication, because the words like this. So this drug is for excessive production of ADH associated with hyponatremia or acute heart failure. Okay, then we discussed was the growth hormone. So with growth hormone, remember, so this, just make sure that we are on the same page. This is also called as somatropin. So just look at the spelling, it's somatotropin, right? But if we have another one, which is a recombinant form of this drug name is somatropin, right? Somatropin. But the growth hormone is called somatropin. Okay, so what is this? This is anterior pituitary hormone. And then how this is mediating effects via IGF. And not only this hormone is required for attainment of normal adult size, this is also implicated in lipid and carbohydrate metabolism. How? So if you see that this growth hormone, it has anabolic effects on muscle and catabolic effects on adipose cells. So what will do, this will increase muscle mass and reduce adiposity. So if you have deficiency of that, it will actually do opposite. It will induce obesity, right? And this is critical that the growth hormone, it has what it does basically, it increases blood glucose level, whereas IGF has insulin-like effect, means it's gonna decrease blood glucose level. That's the reason, along with this administration, you need to give where's something we discussed something like that. So when prescribing this IGF, you have to take this carbohydrate-containing meal or a snack 20 minutes before and after treatment. Okay, and then basically we discussed that in neonate stage you don't need that because it's not dependent on growth hormone, but here you will see that this is required because in childhood you will see a short stature with mild obesity, but in adults you will see generalized obesity and dyslipidemia and reduced muscle mass. And so in this table we're looking at. So if the question asks you that what would be the manifestation of growth hormone deficiency in adults, then you should be able to identify this. Then basically you have this table, which is this reads as, this title is Primary Therapeutic Objectives and Clinical Condition. So primary therapeutic objective is basically, let's say you want for growth, and so basically these what you want to achieve, and this is basically what are the conditions, or what are the situations in which you would want to use growth hormone. So if you remember this, I mean, that doesn't matter how the question is how the question is asked, basically. So I think so. I had this question in PBL quiz. So we had something which was that it has. I had all these options, and then I also had that it has a very powerful anti-aging effect. Well, that was not true, because actually we don't have that enough evidence that it could be having an anti-aging effect. Okay. And then the growth hormone treatment increases the cytochrome P450 isoform. So this is an enzyme responsible for metabolism of this different drugs. So if this enzyme or this hormone increases the activity of this enzyme, what will happen if the drug is metabolized by this enzyme? So the concentration of that drug will be decreased. So you need to adjust that. Okay, and then let's say you got a situation in which you have a case in which the person is not responding to growth hormone. So in the situation you have person not responding to growth hormone, you have this drug which is mescaramine and mescaramine renfabinate, which are a recombinant form of IGF-1. So let's say if you get a case, if the question asks you how the growth hormones affect RBA3, so the answer is IGF-1, right? And let's say if you have a situation in which the growth hormone is not working in a situation, what would be the next step? So these drugs called the IGF, recombinant forms of IGF, that should work. And remember, it is required the carbohydrate meal is consumed within before 20 minutes of application of this drug. So then we had a situation in which you have excess of the growth hormone. Then you would so these are some conditions, acromegaly and the gigantism. So in these conditions you will use an antagonist, right? And if you see this negative sign here, so somatostatin that negatively regulate release of growth hormone from anterior pituitary. So so we have these antagonists like octoroid, pegosamint, and lenratoid. So these are drugs that are antagonists. So especially this octoroid is 45 times more potent than somatostatin in growth hormone release. So let's say if you're a case that you got diagnosis of this the growth hormone excess along with this situation called acromegaly, what could be the ideal treatment or a treatment in this situation? So we can have this octoroid, which will how this is gonna produce an effect, because it's gonna inhibit the growth hormone release. Okay, then we basically discussed was prolactin, right? So remember, the prolactin was secreted from hypothalamus to pituitary, and then pituitary releases the prolactin hormone, which is basically responsible for mammary gland development and milk production. So it's unfortunate we don't have any drug which can actually use in case of we have prolactin deficient patients. But we have a number of drugs which can actually elevate this prolactin level, and that could cause hypogonadism, and which can manifest itself in fertility in both women and men. So, so if you know this information, right? So how can we treat it, right? So if you see this dopamine and negative sign here, so dopamine is actually inhibiting this pathway. So if you have dopamine, it will actually decrease the prolactin secretion. So that makes this drugs or agonists as a standard first-line treatment for the treatment of hyperprolactinemia. So these are the different. These are examples of those two drugs: carbapenem, bromocriptine. Yeah, so I mean, I just remembered that I mentioned that there was a horrible drug which I forgot during the lecture. Remember, this is an advice I really want to give you guys. For exam, please have a good sleep. If you don't sleep, it's very difficult to retrieve information, or you forget tons of things. On that day, or on previous night on that day, so I just slept for 3-4 hours. Today is also the same thing, but I can take it. I can sleep a little longer. So the example of that herbal stuff is fenugreek. It's called methi. But I'm not gonna ask that. That's just for your information and advice. Please take a good sleep. And then so these are drugs which could be used in case of hyperprolactemia. Okay, I think so. That's all I really want to say in this chapter. I hope that helps.